Our first speaker will be Dr. Ahaghotu, and let me just take a moment to tell you a little bit about Dr. Ahaghotu. Dr. Ahaghotu received his medical degree service from Nigeria and is the chief of urology at the Howard University Hospital. And at this time, we'd like to have Dr. Ahaghotu. Next slide, please. Next slide. And Dr. Ahaghotu, we talk about understanding the prostate cancer crisis in Black America.
Thank you, Dr. Shelton. And it's always a pleasure to stand in front of a group of proud men to talk about a subject that I find to be very personal to me for a lot of reasons. Just outside of a year ago, I had the unfortunate circumstance of having to bury my senior partner, Dr. Aaron Jackson. I don't know if any of you have heard of him. Dr. Jackson was a actually world-renowned urologist who was the chief of urology at Howard University for almost 4 decades. Dr. Jackson was diagnosed with metastatic prostate cancer, and we'll talk a little bit about that over the course of the morning, which is when the cancer has already spread. That's what we call metastatic. And he was diagnosed with that about 3 years ago and fought a tough battle, but unfortunately succumbed to the disease on February 28, 2012. And so this is a urologist who has treated thousands of patients over the course of his lifetime for prostate cancer. So as you can see, the condition is not, no one is immune to this condition. And we'll talk a little bit about the problem or the epidemic of prostate cancer in the African American community. The other thing I wanted to say is that I personally do not have an issue with speaking to small groups of men. I think that, obviously there's a hope and expectation that more and more folks will want to come to these kinds of activities. But the reality of it is, if I'm able to touch the life of 1 or 2 folks in the room, then that's really what it's all about for me. I mean, even if this whole audience was full, it still does not even speak to the number of men worldwide who suffer and die from prostate cancer anyway. So the reality of it is, this is about us getting together and having that dialogue, and if it's one-on-one, or if it's 1-on-10, or if it's 1-on-1,000, that's okay with me. So I wanted to share that with you, and then also to make sure that whatever information you get today, or whatever you get out of this experience, please be open to passing it on to the next person, and look for those opportunities to help others understand what we're dealing with, because we really are dealing with an epidemic. Next slide. So today, my job is to give you a little bit of information about the statistics of prostate cancer, how common is it, who is it affecting. We'll have others who will talk a little bit about what the symptoms are related to prostate cancer, and then also what some of the treatments are as well. I have to apologize in advance that unfortunately I am going to have to leave before the end of the session. So what I'll ask, if it's okay with Dr. Sheldon, is maybe to answer any questions specifically related to what I'm going to talk about in the next few minutes, so that at least I'll be here to answer any questions. And if you do have specific questions of prostate cancer, maybe I can answer some of those as well. So, as Dr. Shelton mentioned, prostate cancer is an epidemic in the African American community. Men of African descent, African Americans, African Caribbeans, and Africans have a much higher incidence of getting prostate cancer, and what's even more alarming is that we're much more likely to die of the disease. We're 60% more likely to get it, and we're almost 3 times more likely to die of it when we do get it. So as you can see, it really is a problem. And we'll talk about some of the reasons why this may be the case. So the slide up there kind of gives you the breakdown of the incidence of prostate cancer and mortality, which is the associated likelihood of, unfortunately, dying of prostate cancer if you get it. And you can see there, at the top of that table there, says African American, and you can see that that incidence is 236, and the closest one is almost half of that number. And then in the death rates, it's almost a third of that number. So you can see that that's a pretty dramatic difference in death rate from prostate cancer. Next slide. I'm sorry, next slide. Thank you. This is a little busy, but I'll turn your attention all the way again close to the top under number 2, where it says Washington, D.C. And you can see there that African American men in the Washington, D.C. area have some of the highest death rates of prostate cancer in the nation. And this is the probability of dying of prostate cancer if you're diagnosed with prostate cancer. And you can look at all the other areas on the East and West Coast and in the Midwest, and Washington, D.C. is right up there at number 2. And then on the other table on your right, you can see at the bottom, Maryland is number 16. So you can see in the D.C. area specifically, we have a real epidemic of prostate cancer. So not only do we have a high chance of getting it, but when we do get it, for some reason, we're not able to survive this disease. So it's a real problem in our community. Next slide. Next slide. So what are some of the factors? Because this is what I hear all the time, and I was so happy when Dr. Sheldon showed me these slides, which he and Tom and others put together. You know, I always get the question, why is it there the difference? Why is it that we tend to die of prostate cancer more than anybody else in the world? Well, that's a good question. These are some of the possible reasons, and we'll talk about them. One is we believe that there are genes that code for prostate cancer. And not only that, we believe that there are genes that code for a more aggressive form of prostate cancer. I don't know if you heard about the recent Supreme Court ruling on Thursday stating that it is not legal to patent genes. And what that means is that there are some companies out there that are going and identifying certain mutations in the genome, that's what makes us who we are, and saying that they're the only ones that can use that, that sequence of genes for commercial reasons or whatever. Well, the Supreme Court is saying that no, that the genome, the genes in our body is part of our natural environment, and that companies do not have the right to do that. And so hopefully what that will do is it will make it easier and cheaper to be able to get some of these genetic tests and to do some of these genetic studies. And so we're hoping that by doing that, that might give us more chance of understanding why the genetics of prostate cancer is more lethal in African American men. So hopefully over the next few years, we'll have more information for you. And ideally, what we'd like to do is you could walk into a doctor's office and do a blood test, and it can tell you what your risk of getting prostate cancer is, just like in breast cancer. In breast cancer, there are genes called the BRCA1 and 2 genes that women can go and get tested for. And if they get tested for, it can tell them what their risk of getting breast cancer is. And as you heard again recently in the news, Angela Jolie actually tested and then decided to have her breast removed so that she would not develop breast cancer, because apparently her risk was almost 80 or 90% that she was going to get breast cancer in her lifetime. These are some of the things, and I'm not advocating that everybody go out and have their prostate removed, but getting a better understanding of who's more likely to get it, even more so than what we know now, I think is helpful. So genetics is a big reason. Another issue is not understanding that we're at risk. I cannot tell you the number of conversations I've had with men either in my office or outside of my office who did not really understand that prostate cancer is a problem for us, that we as African American men have a much higher chance of getting prostate cancer. A lot of men didn't even know that. So this activity through PHEN and other advocacy groups, awareness groups, is critical in getting that word out. So when you're sitting at the golf course or sitting in meetings or whatever, having conversations with men, when it comes up, be vocal and tell them that, you know, prostate cancer is a big problem in African American men, and if you're at the age of 40 or older, you need to have a conversation with a health professional about whether you should get tested. Okay. The other issue is that African American men, for some reason, and we don't know the reason for this, we are more likely to be diagnosed with prostate cancer when it's more advanced. So you have 4 stages to prostate cancer, and someone I believe is going to talk about this later. You have stage 1, 2, 3, 4. 4 is when the cancer has already spread, and it's impossible to treat then. 1 is when the cancer is still in the prostate, and it's pretty easy to treat. So we as African American men are more likely to get it at that more advanced stage. In fact, we're 4 times more likely to get it. And because we are likely to be diagnosed with it at a higher stage, it's less likely to be treatable, and therefore we're more likely to have problems or even to die from prostate cancer. So that's another important reason. Tom Farrington and many others talk about the fear and the silence around prostate cancer. What does it mean to be a man in our community? What are some of the challenges of having health problems? What is that going to mean for us in terms of our ability to be productive, to provide for our family, to keep our family? These are things that we often don't have a venue to talk about. And so, you know, this is the kind of venue where we can talk about these things. And I can tell you right now that early stage prostate cancer is treatable. You can go on and have a good, healthy, productive, fun life after being treated for prostate cancer. As you can see with Dr. Sheldon, Tom Farrington, many other survivors, Dr. Kennard, and many others have gone on to have wonderful lives after being treated with prostate cancer. So you don't have to be afraid. But the first thing is, let's talk about it. And that's what we're doing today. The other issue is related to not understanding all of the treatment options. So there was a large study that showed that if you're African American, you are less likely to be offered some of the state-of-the-art treatments that are available for prostate cancer. Well, we can talk about health inequity or racism. We can talk about access, whatever. But the point is, if we're not being offered, or if we don't have access to some of these newer and better treatments, then obviously we're not going to do as well if we're diagnosed with the disease. So this may be part of the conversation as well. How do we make sure that men of African descent in the United States have access to the same kinds of treatments for prostate cancer than everybody else? So these are some of the reasons or issues that we believe revolve around why men of African descent are more likely to die from prostate cancer than other folks. Next slide. So as a result of the wonderful efforts of Tom Farrington and many others and the PHEN group, the Congress, led by Senator Kerry, has declared prostate cancer in epidemic proportions in African American men. This is a U.S. Senate resolution. Now, this is a big deal, even though it doesn't have any money attached to the budget or what have you, but what it means is that the Congress has recognized that prostate cancer is a problem specifically in the African American population. And what that is going to give those of us who go to Congress and other places to talk about policy, it gives us a tool to now say, okay, these are the things we need to start looking at. Research, community engagement, funding for all kinds of activities that will help us to hopefully get a better handle at why this condition is going on in African American men and what are some of the strategies that we can use to address them. So, next slide. I think that's the last slide, I believe. Let's see if there's, yeah. And so at this point, I will end my formal conversation or presentation and open the audience. Do you think we have a couple minutes for comments or questions? Certainly, I always, and I hope I don't put them on the spot, would love to get some input from my good friend. I would like to hopefully have the honor of being able to say a good friend, and also as your physician, whether you have any comments about the issue of prostate cancer, and then we can maybe open it up to the audience. Thank you. Yes, Dr. Kennard.
Doctor, one question. As you were talking about the disparity in detection and treatment options and so forth, this might sound odd coming from a scientist, but I want to ask the question you could probably answer. Is there something in our genetics that presents itself and makes it harder to detect at an early stage, which may contribute to the disparity in the incidence in the black community?
And that's a very interesting question. I don't think I've heard that question before. And just to put it out there for anyone who may not have heard it in the back, the question from Dr. Kennard is there something in our genetics, in African American men's genetics, that makes it harder to detect prostate cancer at an earlier stage? And that very well may be the case, but I suspect that it's a little bit different. I think that one of the reasons why we as African American men tend to present with more advanced disease is that the disease inherently is more aggressive, so it grows faster. And because it grows faster, the standards that we use for detection may not be as effective. So the recommendations about screening and detection of prostate cancer are based on research that's been done over the last 3 or 4 decades as to, who should we be checking early and how should we be doing that. Well, let me just tell you that research that's been done over the last 3 decades has been done primarily on white men, okay? And so the standards that we use to detect prostate cancer or decide not to detect prostate cancer is based on studies looking at a group of men that's not in this room. So the real challenge now is to make people understand that we count. And because we count, we need to put funds in to do studies looking at prostate cancer in African American men specifically, and come up with strategies to get more African American men involved in these studies and research so that we can understand how that disease works in us a little bit better and create standards that are specific to us. One of the things that's a really hot topic right now, and I don't know if any of you all have heard this in the news, there's a recommendation out there by an agency called the U.S. Preventative Services Task Force. It's just like the Center for Disease Control and some of these other agencies that are funded by the federal government. And this specific group is supposed to make recommendations about certain testing for certain kinds of diseases. Well, the U.S. Preventative Services Task Force last year put out a statement that we shouldn't even be doing PSA testing anymore. They said that it doesn't save lives, that it's not effective in reducing the likelihood of dying of prostate cancer. They based it on studies that were done on white men. There were very few African American men that were done in the studies that led to that conclusion. And despite a year of protest and pushback by groups like PHEN and many others, including people on the Hill, congressmen, lawmakers, this agency upheld its position not to recommend PSA testing. And what that effect may happen is that insurance companies may stop paying for it. And not only that, when you hear that message, when you're sitting in front of the TV or wherever it is you get your information, you may say, well, they're saying I don't need to get screened, so I don't even need to have that conversation. Well, I'm here to tell you that really that conversation is a lot more complicated than they're making it out to be. So these are some of the issues why we believe that African American men are dying more likely from prostate cancer than others. Yeah, good point. Yes, sir, in the back. All 3 very good questions, and I'll try and address them one at a time. First of all, talk about money. $2 $2.5 trillion. Remember that number. That's how much money is spent on healthcare in America. There's no doubt about it. It's a big business. And I want to believe that most healthcare providers do not make decisions primarily because of economic reasons. But guess what? I'm not that naive either, okay? But let me talk about the biopsy. So we didn't really get to that conversation yet, and maybe that's why we kind of went out of sync here. But just to tell you very quickly what a biopsy is, when you get that blood test to check for prostate cancer, it's called a PSA test. If that test is abnormal for whatever reason, the doctor may tell you need to have a biopsy. It's basically a simple test, at least from a doctor's description, where the doctor gives you a sedation or gives you a little anesthesia and uses a tiny needle to get some samples from the prostate to see whether there are any cancer cells. That's how we diagnose prostate cancer. Now, this biopsy, or the decision to do the biopsy, is based on that PSA test. And because we don't understand completely how accurate that PSA test is in predicting prostate cancer, different people make recommendations about the biopsy. So there isn't a really good standard. That's what this is about. And so for some doctors, they may do the PSA at lower levels. We do know that because African American men were trying to find out a way to find our cancer earlier, we lower that number a little bit. So what may be low for somebody may not be low for another person. So if you have a family history of prostate cancer, or if you are African American, we may recommend you getting the biopsy at a lower level of PSA than somebody else. So that's the question of why we would do a PSA where it may not look like it's so high. I'm hoping, again, that the decision to do the biopsy isn't based on somebody trying to make money. But like I said, I'm not naive. I'm sure that there's some unethical people out there. But I want to believe that the majority of providers who do biopsies are not just doing it for financial reasons. Now, the other issue of getting a negative biopsy and then wanting to have them come back and do another one. Well, when we do that, when we use that needle and stick it in the prostate, I think of it like this. Imagine you had an apple and you had a little rotten part of the apple somewhere in the core, right? And then you take a toothpick or a needle and you keep sticking it in that apple to try and see if you can find out where that little rotten area is. But you can't see it, right? Because the apple's covered with red, right? That's essentially how we do a prostate biopsy. It's a random process. So when we do that biopsy, you may have a spot of cancer there that we missed. And so if your PSA keeps going up, even though your result was negative, the doctor may recommend that you get a repeat biopsy. But that process of making that decision has to be a very thoughtful and calculated decision. And so usually we don't do 2 biopsies in a year. I mean, that sounds a little bit odd, but again, I don't know the details of your particular case or the case you're describing. But it is possible to have to do a repeat biopsy, but usually not within a year. And the reason why we do the repeat biopsy is based on what I just tried to describe to you. So hopefully, I don't know if that helped to answer some of the questions that you had.
Yes, it did. What about the spray?
Oh, yes, I'm sorry. That was the other thing. So the question is, if you do a biopsy of the prostate, do you increase the chances that that cancer is going to spread? And the answer is absolutely no. I hear that a lot, and that's a sort of an urban legend out there, but I can tell you, spread the word that doing biopsies does not increase your risk of spreading the cancer if you have it. It's never been proven in any of the literature on prostate cancer. So I guess we're going to have to...
One last question.
Oh, okay. Yes, sir.
It's evident that one of the things that you discussed earlier, just looking at the number of people here, it's evident that we as African Americans, we're developing this fear. Sometimes we feel like we're less than man or something like that. When we talk about prostate cancer. I was fortunate enough to have we don't even talk primarily about ourselves. We'll use it on others. But at any rate, I had 6 months of PSAs, and they were like fluctuating between 4 and 4.5, and then 9, and then 9 again, you know, and then 4. So ultimately, I had a biopsy, and 12 samples were taken, and 6 came back positive for cancer. And I think that the ratio was like a 6 or something like that. But they also sent it back out to Johns Hopkins to have them look at it again. Now, my question, I was fortunate enough to talk to Dr. Kanai earlier, and I was trying to, you know, in determining what's the best treatment for a person that was, you know, had a ratio of PSA as a 9, as opposed to somebody that's in the fourth stage. What people recommend is the most effective treatment. And from my understanding, I had talked to several people and talked about the pellets and radiation. And again, I was fortunate enough to talk to Dr. Kanara, and that was one of the things that he said that he suggested in the treatment. That do you have a consensus of what's the best treatment depending upon the stage? Because I have an uncle who's 85, and he had his prostate completely removed about 8 years ago.
So that's a good question, and I think also we have Dr. Horton who's here. She's a medical oncologist who specializes or focuses on prostate cancer, so it's good to have her here, and I'm sure she will comment on that as well. But just from a urologist perspective, and I think I'm a balanced urologist, I think I do a good job with talking about all the options, and we won't go into too much detail, but the quick answer is no. There really is not an ideal across the board clearly better treatment for early stage prostate cancer over the other. It's all about risks, benefits. So there are some advantage to radioactive seeds, and there's some disadvantages. There's some advantages to having surgery and some disadvantages. I think the best way to make a decision that's right for you, because it's an individual decision, is to have a clear understanding of the effectiveness of the treatment. That is, the probability that this treatment, in your case, is going to result in cure over a period of time, because it's a probability. There is no black and white. It's chances of you not having cancer in 10 years. That's how we look at it. And you have that on one hand, and then on the other hand, you look at your risks related to the procedure. You know, complications specific to you and complications specific to that treatment. And then you weigh that. And I think the real challenge, and this is one of the areas I'm very interested in, is how do we communicate that message to men in a way that they can decode it, own it, and then be able to make that meaningful decision for them. Because I think that what happens so often is that our patients are often deferring the decision to the doctor. And they're doing it in different ways. And I don't think that they're doing it because they trust us so much. I really think that they're doing it because they've given up the ability to understand and really make that decision for themselves. The way we're communicating it may just be too complicated. It may just not be a way that they can process it. And by doing that, they're just saying, okay, well, doc, you know best, you do it. But that may not really be what they feel. Now, I don't know that, that's a hypothesis, but the point I'm trying to make here is that, you know, whether it's, you know, brachytherapy is an excellent form of therapy. It obviously worked extremely well in some patients' situations. But surgery is also a very effective form of therapy as well. We even do robotics now. So I think the key for you in making this very, very important decision is to be able to understand what the effectiveness is and what the side effects are and what you're willing to live with. Because when you do that, then whatever decision you make, I think you'll be more comfortable with that outcome. Yeah. Okay, thank you very, very much. Sorry I can't stay.
Dr. Ahaghotu, thank you very much for that very in-depth, overview. Thank you very much, sir. As we open up the program, the symposium, as I said, PHEN was really very appreciative of the churches that partnered with us and hosted this symposium, the Educational Symposium on Prostate Cancer. I'd like to just, briefly before we go on to the next speaker, I'd like to recognize the Reverend Watley here, who really hosted this symposium at Reed Temple North. So thank you very much, sir, for the opportunity to be here. Okay.
I got another meeting
Sure, sure.
and say,
Hey,
"Listen, brothers,
Good morning, brothers and sisters. Just wanted to stop by my daughter and I to say good morning. We have another, well, I have another meal. I'm going to give it to her aunt in a minute. But this is such an important opportunity, and there's so much important information. I've just been sitting here thinking about how we can more effectively get this information out. And so I'm going to get with the Anglos Ministry. We'll put together a video, put it up online, and also hand it out. And that way some other brothers can get a hold of it and make the barrier of entry a little bit lower. Amen? Amen. Thanks so much for showing up, and thanks so much for coming out. Bless you.